Hello, everyone, and welcome to Preemie Chats, a space where we connect, learn, and share stories about the world of prematurity. I'm Leah Whitehead. I'm a proud preemie parent and a former journalist, and I'm happy to be your host today, and I'm so honored that you chose to spend your Friday afternoon with us. Preemie Chats is brought to you by Canadian Premature Babies Foundation. You may also know them as CPBF, a parent-led charitable organization dedicated to supporting families, advocating for the needs of premature babies, and providing the latest information and resources to help parents and caregivers navigate this journey. So whether you're a parent, a healthcare professional, or just someone who's interested in learning more about prematurity, you've come to the right place. Together, we're building a supportive community where stories are shared, questions are answered, new evidence is explored, and no one feels alone. I'd invite you to please visit our website, canadianpreemies.org. It's there on the screen. And there you will find lots of free, helpful resources for yourself or for your NICU or for families you may be supporting. You'll find our latest projects. And most importantly, you'll find a passionate community of people who just want to see our little ones thrive. If you're watching live today, I'd invite you to join in the conversation. I see some people already introducing themselves. We love to see that. Let us know where you're watching from. And if you have any questions at all during today's episode, just pop them in the comments and we will try to address them at some point during the program. If you happen to be watching a recorded version of today's episode, you can still connect with us through the website. And it is through meaningful conversation like the one that we're about to have, where we advance, practice, and grow together. So again, let us know where you're watching from. It's always interesting to see where our audience is tuning in. Now, it's no secret, we can all attest that NICU is hard. After being in NICU myself with my preemie and then working in NICU for 10 years in a peer support capacity, I experienced firsthand how it really didn't matter if you were in NICU for a short amount of time, like hours, or if you were there for months on end. NICU is difficult. NICU bedside staff are incredible in offering emotional support, but it really takes a team of people to make sure that families are getting the help they need. I'm really excited for today's chat. We have a NICU psychologist, and it's a role that not every NICU has, but it is an important one. And so she'll be talking about the importance of mental health care that psychologists can help with, the impact on NICU parents' overall well-being, the relationship between the parent and the infant, and baby's overall development. I'm happy to welcome Dr. Tiffany Gladdis today as our guest. She is an associate professor at the University of Missouri, Kansas City, and perinatal neonatal psychologist at Children's Mercy Hospital. She supports families in the Fetal Health Center, the Neonatal Intensive Care Unit, and the Neonatal Follow-Up Clinic. Dr. Gladdis is medical director for the Office of Equity and Diversity at her hospital. She's on the board of directors and a founding member of the Missouri Association for Infant Mental Health and Early Childhood. She's on the executive committee for the National Network of NICU Psychologists and an executive board member for Hand to Hold. She has lots of rich experience to bring today. Dr. Gladdis is also the owner of Hope, Love, Heal Therapy and Consulting, where she provides therapy, training, and consultation to organizations nationally. She's particularly interested, and I love that she's going to be talking about this, in attachment and bonding, trauma, infant and perinatal mental health, and empowering families who identify as Black, Indigenous, or persons of color. She brings so much to the table, and I so appreciate you giving us your time and being here today, Tiffany. Welcome.
Thank you so much for that warm introduction. And I am very excited to be here to talk with all of you all as well. I was sharing with Leah that I'm so passionate about this work. I get to wear a lot of different hats, but as a NICU psychologist, that's really my favorite one. So I'm looking forward to the conversation today.
I know you have a lot to share, so I'm going to bring up your presentation and let you dive right in.
Okay, wonderful. Well, as Leah mentioned, as you guys have comments or questions in the chat, I encourage you to engage with the content as we go. And we'll just kind of jump in. So our primary objectives today are going to be to discuss the role of psychology in the NICU and what it looks like. And it does vary from institution to institution. And so this is just a reflection of what it looks like at our institution, although there are lots of similarities and overlaps, as I learned with most of my colleagues that work at other children's hospitals where they serve as the psychologist in the NICU. And then also we're going to address the impact of parental mental health on the developing infant. So just the intro again of the psychologists that are in neonatology at Children's Mercy, myself, and then my colleague, Dr. Mandy Williams. I've been at Children's Mercy in this role it'll be 10 years in November, which has gone by super fast. And then Dr. Williams joined us this past October, which I'm so excited about because she has helped expand the reach of what services we can provide families. So it's the two of us. And then we also have a team of social workers. And so what do we do as psychologists in the NICU? Often when I tell people I'm a psychologist in the NICU, they kind of squinch their eyebrows and tilt their head. And I always imagine there's like a thought bubble above their head and they're imagining like babies on a couch and wondering, are we like psychoanalyzing them or something? And then they say to me, what do you do as a psychologist in the NICU? Which I love getting that question because I love providing that answer. And it's not psychoanalyzing babies on the couch, but babies are very much involved in the work that we do. And so I'll kind of paint the picture for everyone about how we use the intervention of therapy with parents for the benefit of our little ones. So first, I want to talk about the areas that we cover. So our Fetal Health Center, which is where pregnant people come when an anomaly has been identified in the pregnancy for high-risk OB care. And this Fetal Health Center is attached to our hospital. In fact, it's right across the way from our NICU, so that when parents have their babies there, they are immediately taken right over to the NICU. And the beauty of that is that there isn't the separation of like the baby having to be life flighted to a different hospital or the other parent having to decide, do I stay with their partner or do I go with the baby? It's all right there on the same unit. And so that's really beautiful. And we do serve families in that clinic. But our primary area of service is in the NICU. And then we also have a neonatal follow-up clinic where our NICU babies go for follow-up care after they discharge from the NICU until they're about 2 or 3 years old, sometimes 4. It kind of just depends on the individual and how they're doing developmentally. And what I love about getting to serve in all 3 areas is that there is a continuity of care that we are able to provide as a psychology team that's really outstanding. So there are some families that I've worked with from pregnancy all the way until their kiddo is 3 or 4 years old, which is just really amazing for us to see kind of the trajectory, and also for the family to have someone that's with them throughout that process that knows and understands all of their challenges and is able to celebrate all of their successes because we've literally walked the journey with them. Our primary focus with the therapy that we provide is supporting parental mental health, because we know that it is challenging being in the NICU. The NICU is a trauma environment. And unlike most traumas, it's not a single incident trauma. You know, when you have a car accident or you are part of a robbery or something of that nature, it's a single incident, and then you have the opportunity to then process and heal. But when you're in the NICU, it's not a single incident trauma. Oftentimes, The pregnancy may have been traumatic, the delivery is traumatic, and then being in the NICU itself is also traumatic. So the trauma, it compounds itself. And so it's hard to imagine that anyone could really get through the NICU experience in a healthy way without additional support. And so I wish that more NICUs had psychologists, and I'm really happy to be able to say over the last 10 years, this area has really grown. Leah mentioned that I'm part of the national network of NICU psychologists, and it's just beautiful to see that network grow year after year, because so many more NICUs are adding NICU psychologist positions because they recognize the importance of not just treating the baby, but also being able to provide support and treatment when necessary to the parents. And so not only are we supporting the mental health of the parents, but we're also promoting healthy bonding and attachment between the primary caregiver and the infant, which we'll spend a good deal talking about today. And then also addressing infant and toddler developmental and behavioral concerns. And most of that for us is done on the outpatient side, but there are definitely aspects of that work that are done even simultaneously with the life-saving care that's happening while baby is in the NICU. So when I first started at Children's Mercy, the psychosocial team, which consists of the social work team, who are phenomenal, and I came up with this Venn diagram. And the reason why we came up with it, which I see it transferred a little bit, so I'll read that. But the reason why we came up with it is because for the medical team, it was kind of like, well, what is the distinction between social work and psychology in a NICU setting? And it can be confusing because there are overlaps, but there are things that are distinctly different. So in our NICU in particular, our social work team is responsible for crisis management, completing the psychosocial assessments for the families to determine, what their life stressors are, their socioeconomic stressors, financial stressors, and helping connect them to resources. For example, our Ronald McDonald House or housing or financial resources, or even getting them connected with the right insurance. And then they also provide ongoing support as far as adjustment to hospitalization and helping kind of coordinate between the team, different things that might be happening. Where there is overlap in what we do is that both groups are providing emotional support for families. We are both a liaison between the family and providers, so advocating for our families when we need to, and being empathic listeners. But where the psychologist team differentiates the service that we provide to families is that we get to do therapy, which is a real privilege because, as many of you know, the NICU experience is very personal. It's very intimate. It's very difficult. And through therapy, we get to intimately understand and know what the experience and the challenges are of parents as they walk this journey that nobody asked for, and many people were not expecting or planning to have to experience. And so it's really, I really see it as a privilege and an honor to be able to walk that journey alongside parents. So we're doing cognitive behavioral therapy, solution-focused therapy, psychodynamic therapy, those type of approaches in order to help parents build the skills that they need, develop ways to cope with the trauma, the depression, the anxiety that they might be experiencing as a result, the grief that they might be experiencing as a result of being in the NICU. And then, of course, that attachment and bonding work. We also are there to provide staff support. So working in the NICU is also hard. It's a very intense environment. It's a critical care atmosphere. And there are really hard things that happen. And so there's vicarious trauma that is experienced by the team, especially by our nurse partners. And so we're there to provide support to our medical team as well, even if they're just having challenges on how do I interact or engage with this family. they seem resistant to care, or they seem not to be understanding what we're communicating, or they're not coming in. And we're able to offer a different perspective of what might be going on with the family, kind of that trauma-informed care perspective of, what happened or what's going on with the family versus what's wrong with them. And through that lens, we're able to help the team then meet the family where they are, so that there can be a kind of a shared collaboration of reaching whatever the goals are for the team or for the baby. And then when appropriate, we can also provide assessment. So in our clinic or in our NICU, these are some of the reasons why someone might provide a consult for psychology services. And we really have socialized in our NICU that anybody can do a consult. Sometimes it's the unit secretaries that build the relationship with the families and can kind of know when something is going on. Maybe it's the bedside nurse, maybe it's the nurse practitioner, maybe it's the occupational therapist. Whoever it is that may have a concern about the well-being of a parent can make a referral and say, hey, I think psychology should check on this family. And so things like parental conflict or attachment concerns, or if there's a history of a mental health condition, or if there's a difficult staff and faculty interaction, or a previous loss in the NICU or loss in general or previous NICU experience, all of these are reasons why we would encourage people to make a consult to psychology. And then we also have a few categories where we automatically want a consult to be placed, because we know these are categories that are more stressful and where families are likely going to need additional support. And in our NICU, we really do try to normalize the use of a psychologist. And so when we reach out to families, we do explain to them that this is part of one of the services that are offered, just like you might get a consult to neurology or physical therapy. Psychology is there embedded in the system to make sure that we're caring for the whole family unit. So if a family baby has a diagnosis of neonatal abstinence syndrome or extremely low birth weight, or a trach consult is placed where we know the family's life is going to be tremendously impacted by going home with a baby who has a trach and is on a vent. These are some areas where we automatically say, hey, we want to be involved in the beginning just to normalize that this is difficult and that support is available. So in our outpatient setting, some of the reasons why families might get referred are similar, but there are some differences. So in this setting, we're able to also help with some of the normal developmental and behavioral presentations that might occur, like difficulty with the feeding schedule, or challenges with the sleep routine, or as the babies get older, biting, hitting, tantrums, the parent not feeling attached, or just stressed and overwhelmed. Because one of the things that we know is that while parents are excited to discharge and go home and start their life apart from the NICU, that can also be a very scary thing, because they have had the support and the oversight of the medical team, and now going home means doing it all by yourself, or sometimes it feels like that. Even though you might still have the support of an outpatient clinic or doctors that you can call or nurse lines that you can call for questions, it feels really different to transition from the support of having a nurse there all the time and being able to look at monitors and see, your baby's respiration rate or their heart rate, to going home and feeling like, okay, it's just us here now. And so sometimes that can be really overwhelming and stressful for parents, even just making that transition. And so those are reasons why we might be able to get involved either for the first time, or again, continuing the relationship from the NICU to the outpatient setting. The other thing that we're able to do in the outpatient setting, which is very important for babies in the NICU, is developmental surveillance and evaluation. So like I mentioned before, babies are seen in our clinic until 2 or 3 years old. And so along the way, we are doing developmental screening using a questionnaire. We use the ages and stages questionnaire, and we screen them between 5 and 7 months and at between 11 to 13 months formally. But also we do this as needed. So if there are concerns from the doctor, they would administer the questionnaire at whatever age range the child was at the time. And then we routinely do a full developmental assessment with babies using the Bailey between 19 and 36 months. It really just kind of depends on the kiddo and when they're ready to graduate. It's kind of the last step before we kind of bless them to move on and no longer be followed by our special care clinic. And this assessment looks at development in the areas of cognitive, language, and motor development. And we also have an adaptive functioning component as well. And this is just our standard of care. And really, most kids at this age, once they have the developmental testing, already have therapies on board. But before we graduate them from the clinic, this testing is just to ensure that based on where they are developmentally, they have all of the supports already on board. And perhaps, for example, if we find that the child is delayed in language and they don't have speech therapy on board, this allows us to then make that recommendation before they're able to graduate from our clinic. And it also is a great baseline so that now, as they're a toddler and they're going into preschool and getting ready for kindergarten, this gives us a baseline score to track their development over time and ensure that interventions are impactful. So I've just explained kind of what we do, and now I want to talk about why we do it. So this is kind of the meat here. So the foundation, the theoretic foundation that we operate from as psychologists in the NICU is infant mental health. And infant mental health can be a little bit misleading, or maybe not misleading, but a little bit confusing, because again, that goes back to the babies on the couch. But essentially what infant mental health is it considers the relationship between a child and their primary caregiver. So the patient, in a sense, is the relationship between the dyad. And so one of the things we know is that having a secure and healthy attachment between an infant and their primary caregiver is foundational to all other development. It is the foundation to language development, to motor development, to cognitive development. And so it is really valuable that while babies are in the NICU, we are also thinking about how do we facilitate a healthy attachment between the parent and the caregiver. And it's not something that can wait until the child goes home. Like, oh, well, when they go home, we'll work on, bonding and attachment. And the reason why is because there is a critical period where healthy or a secure attachment is formed. And theorists believe that's 0 to 2 years old, but some theorists would even say that window is even narrower. So 0 to 12 months. And I tend to lean more on the 0 to 12 month side. And in our NICU and in other NICUs across the country and the world, some babies are in the NICU for a majority of the time in that critical period. So we have, actually today, we have a baby celebrating their 1-year birthday. In 2 weeks, we have another baby that's celebrating their 1-year birthday. So again, it's not something that can wait. Because we have this critical window with regard to synaptic connections in the brain that have to be formed during this period. And if they aren't getting the interactions and aren't experiencing the behaviors that help facilitate this healthy attachment, synaptic connections won't happen, or they'll get pruned away. And again, it's kind of like a now or never type experience. And so we do have this biological, the research tells us, desire to be attached and connected to another human being from birth. However, when our babies are in the NICU, they are at a deficit for some of this attachment just by way of the context. So behaviors that help promote attachment are things like physical proximity. Well, parents aren't around the baby 24/7 when the baby's in the NICU, and shouldn't be, right? They need to take breaks. They have to step away. They might have other kids at home. They may live hours away from where the NICU is. They may eventually have to go back to work. And so physical proximity is impacted. Physical touch is important. Taking care of basic needs, so diapering, temperature regulation, and then verbal interaction. All of these things help build a secure, healthy attachment and bond between the parent and caregiver, but all of these look different when your baby's in the NICU. And I want to talk a little bit about the picture that you guys see here on the screen. There was a study done called the Wire Monkey Study. And the purpose of this study was to examine this idea that is attachment a biological thing that we're born with? You know, how important is this? So they had these little rhesus monkeys, and they put them in a cage with what they called the surrogate mothers. One was the cloth mother, which you can see has the towel wrapped around it. And the other mother was the wire mother, which has a bottle that has milk coming from it. And they wanted to see which of the surrogate mothers the little monkeys preferred. And you can see from the picture that most monkeys preferred the cloth mother because in touch and feel, it most resembled their actual mother. And so this was good evidence of, yes, this desire for warmth and connection and bonding and attachment is biological. One of the things that I think is funny or kind of cute about the study is lots of the monkeys clung to the cloth mother, but then leaned over and suckled from the bottle of the wire mother. So it's not to say that attachment and bonding is more important than the very sustenance of life, but I would argue that it is equally as important. And so healthy attachment serves as a protective factor for our babies for a lot of different things. Heart disease, depression, infection are just a couple of those. So again, our babies start off at a deficit when it comes to building these healthy attachments. So many of our babies are not able to have skin-to-skin contact with the birthing parent right after delivery. Many are not able to breast or chest feed within 1 hour after delivery. And then many are not able to room in with the parent following delivery. So some of those early attachment behaviors are not opportunities that our infants in the NICU get. And again, we want to be mindful of that. And so when we're thinking about the things that could impede the healthy development of a relationship between a parent and a child, there are a number of different things. Things like a traumatic birth, which is common for our babies in the NICU. An undesired or unwanted pregnancy, a pregnancy due to a trauma like rape, severe medical condition or predicted death of the baby is also a very common way to interrupt that relationship. And I just want to pause here for a second, because thinking about our Fetal Health Center families, many of them have been, or not many of them, I shouldn't say many, but some of them have been told because of the medical status of the baby, it may not survive to delivery or may die shortly after. And part of what we do as humans, and often this is unconsciously, there is an emotional distance that we create when we receive that kind of news, because then we feel if the baby does die, it will hurt that much less, you know, if I haven't created this strong bond and connection. But what happens then when the baby survives? Again, you're digging out of this attachment hole that you've created to protect yourself emotionally. And then parental mental health problems like depression, like anxiety, like PTSD, certainly get in the way of building that healthy attachment and bond with your baby when you're in the NICU. And so if we had more time today, which I wish we did, we would go into this a little bit more, but I'm just going to kind of flash this. You may see the term PMADs, PMADs, and that stands for perinatal mood and anxiety disorders. And this term has been used more in the last, 7 to 8 years to really be sure that we are encapsulating the full experience of what parents may experience postpartum. We used to just hear PPD all the time, postpartum depression. And what we know is that number one, depression can happen perinatally, like during pregnancy, not just postpartum, especially if you're one of those parents who get a diagnosis during pregnancy. But also, depression is not the only thing that people experience. We experience anxiety, which includes OCD and post-traumatic stress disorder, and parents can also experience postpartum psychosis. And all of these have the potential to interrupts your connection with your baby, which is where our job comes in as NICU psychologists. We know that the rate of PMADs is greater for parents in the NICU. So 70% of mothers, and this is US data, but 70% of mothers in the NICU will experience depression or anxiety, and 15% of mothers and 8% of fathers will experience postpartum PTSD. So again, this is not something we can ignore, because we need to be able to care for the parent so that they're able to care for, be present for, connect and bond with, make medical decisions appropriately with a clear mind for the child. And so we know that the presence of a perinatal mood and anxiety disorder significantly affects the way a parent interacts with their newborn. And so the job of the NICU psychologist is to be there for the parent, to help give them the coping skills, the resources, to create a container to hold the emotions, the frustrations, the grief that they might be experiencing as a result of being in the NICU, so that they can be as well as they can in the NICU environment, and they are open and available to have this healthy attachment and bond to their child, and vice versa, so that they are creating a healthy foundation for the child's overall development. And that's the gist of what we do and the reason why. And so maybe you guys can join me on the crusade here that like every NICU should have a psychologist for this reason, because too many parents are dealing with the difficulty and the challenge of being in the NICU alone, because oftentimes you don't tell everything to your family or friends because you don't want to overwhelm them, or if they've never been in a NICU before, they don't quite understand what it's like, or you don't want them to worry about you. So maybe you give them bits and pieces, but you don't give them everything. And so having a third party like a psychologist who can really hold space for you, it's just incredibly important. And so what is the effect of parental mental health on infants and toddlers, which is who we do this for? Well, we know that one of the only modulators of newborn stress is the relationship with the parent. So if the parent is not emotionally well, it's going to be really difficult for them to modulate and regulate the emotional experience of the baby. And the baby is going through a lot. They're getting pokes and prods all the time. They're having new caregivers every 12 hours. They have all these wires. They're hearing alarms, other babies crying. It's very stressful being a baby, and especially a baby in the NICU. And so they need a parent that's capable and able to regulate them. They need the nursing staff. They need any adult person interacting with them to be able to modulate their own stress so that they can help the baby also modulate their stress. I like this diagram, and I'm going to kind of explain it. So at the bottom line here, you can see it's saying development. So the baby from birth as they get older. And then the cone in the middle is the baby's capacity towards regulating themselves. And then the outer circle is the adult caregiver who would be helping them regulate. And so as you can see, over time, the idea is that the baby is able to regulate themselves better and better, right? But that takes time. And that is only in the presence of an adult who is initially able to help them co-regulate. And so it transitions from the adult being able to help the baby co-regulate to the baby being able to regulate themselves. But what happens when we have an adult caregiver who isn't able to regulate themselves? It's going to be very difficult for them to then help the baby learn self-regulation skills, which is vitally important. So when we think about the relationship and ask the question of how powerful is it, Oh my gosh, it's incredibly powerful. And we're talking about the relationship between the infant and parent. But if we have any people on the call who care for infants in the NICU, any adult person that has a relationship with an infant is valuable and helps with this attachment building. The research tells us that babies only need one healthy adult to create a secure bond and connection. And sometimes the bedside nurse or the primary nurse might be the substitute in the moment. Maybe the parent isn't able to come. And so it's also important that we really value as healthcare providers the relationship and the bond and connection that we have with the infant. How do we show up? How are we affirming? How are we safe? How are we announcing ourselves to the baby to create expectation about what's happening? Because even our relationship can help with that regulation process. And sometimes that's a substitute for what the parent may not yet be able to do. So caregivers play a critical role in helping build good mental health for a lifetime for the infant. And we know that the quality of early care tremendously impacts a child, even down to how their genetics might be expressed, which we're going to talk about here in a little bit. So the relationship is very powerful. And when we think about this idea of epigenetics, so the combination of nature, our DNA, and then nurture, what we experience in the environment, which is where the relationship piece would come in, we that who we become as people is a combination of both, right? And so the experience of the parent has a direct impact on the fetus. So for example, you see this picture here of the pregnant person. What the mom is experiencing or the birthing person is experiencing during their pregnancy not only affects them, but it affects their baby and affects the reproductive cells that are being created even in the baby. So the stress of the environment, the nurture, is affecting down to a third generation. And so it's important that as we're also thinking about how do we provide that safe, secure, reinforcing, reassuring environment for the baby, the parents are also a part of that. It's a unit. We have to care for them as a whole because this baby's going to go home, Lord's willing, eventually, and with the parents. And we want to make sure that that whole unit is healthy. I want to tell you guys about a study that I think is really phenomenal. And then we just have a couple more slides, and then I'm happy to take questions. And I think this study does a great job of demonstrating the power of relationship. And really, if I had to say anything that explains why our role as NICU psychologists is so valuable, this is what I would talk about. So there was this study done by a researcher named Weaver, and he wanted to look at the impact of nurture. And so he had these rat pups, and he had two different groups of rat pups. He had the high licking rat pup group, and he had the low licking rat pup group. And essentially for rats, licking and grooming of the parent, the mama rat, to the baby is how they do the attachment. It's their attachment behaviors. It's how we snuggle and, hug and kiss on our babies. Licking and grooming is the way that rats do that. And you can see in the diagram here, it says a pup that's raised by an anxious, low nurturing mother becomes an anxious adult, while a pup that's raised by a relaxed, high nurturing mother becomes a relaxed adult. So what they did is they wanted to see how these two different groups of rat pups performed in a novel environment. So they had this big tub, and in the tub, they had some random objects like a soda can, a shoe, a belt. And they wanted to see how the low licking or the low nurture, low attachment rats performed compared to the high licking or the high nurture, secure attachment rats performed in the space. When they put the low licking rats in the space, they were visibly anxious. They were spastic. They were frozen in space. They didn't explore the area at all. They tested their cortisol levels, which is what we excrete when we're stressed. And their cortisol levels they had like skyrocketed. They were out of the roof. Then when they put them back in their cage, their comfortable, familiar environment, the cortisol levels remained high. They did not go back to their baseline levels. And so this was demonstration that this group of rats who did not have a healthy attachment, they did not receive a lot of nurture, they did not handle a stressful situation well. And even when they were outside of that stressful situation, the effects of that were prolonged. But there was a different experience when they put the high licking rat pups in the space, the ones who received a lot of nurture and had a secure attachment with the mama rat. When they put those pups in the exact same space, they were anxious, but they were eventually able to explore the perimeter of the space, which is where we know rat pups feel most comfortable. And then they were even able to go into the center of the space and explore the items in the center. When they tested those rats' cortisol level, our stress hormone, it was mildly elevated, but not nearly as high as the other rat pups. And then when they put them back in their comfortable, familiar environment, their cage, the cortisol levels extinguished almost immediately. They went back to baseline. And so this was a great demonstration that the healthy relationship between a parent and a child, if we're extrapolating this to humans, is vitally important. It helps the infant to be able to manage stress of their environment more effectively and allows their nervous system to be able to operate in a way that is more adaptive and functional. And what we know, we said it earlier, is that infants in the NICU are in a stressful environment. They're going through a lot. And so that healthy bond and attachment is a protective factor for all of the things that they are experiencing and going through. And the only way we're able to help have that secure attachment and bond is if we have a healthy, well-adjusted as possible relative to the situation parent. And oftentimes the only way we can have a well-adjusted, emotionally stable parent is through the course of therapy, somebody who's helping them process all that they're going through. And so there's kind of this cascade of the work that we get to do as NICU psychologists, that while it's with the parent and sometimes with the dyad, it's for the benefit of this developing, beautiful, amazing little human being that just got a rough start in life. And so we also know that when there is not that healthy attachment, there can be long-term impacts on the child. And so I know sometimes when we talk about, attachment and bonding and nurture, it seems like a soft science. It seems, all goo-goo, woo-woo, willy-willy, but there's a lot of hard evidence and hard science that says, no, in the absence of this, there are consequences that our babies experience. We know that they have slower cognitive and language development in the absence of a secure relationship, that babies, even in the NICU, have impaired feeding, which we know then causes them to stay there longer, which then puts them at risk for things like infection, just by way of being in the hospital environment. They could even complicate things more. And then as they become older, they have more disruptive behaviors, older like toddlers. And then interestingly enough, their mental health can also be impacted. Remember, I said what's happening in this critical period is foundational for the rest of the child's life. And so there was a study done that showed that adolescents of parents who were depressed when they were infants are more likely to be depressed as adolescents. And so that to me is really powerful and a really good example of, and there's resilience factors that show up. So I don't want to make it seem like, if you were a parent and you were depressed, because lots of parents are, that it means your child's, not going to be well. But we do know from the research that there is an increased risk. And again, that's why it's so important to have intervention. So there's so much more that I would like to talk to you all about, but I want to give you time for questions. And so thank you so much for listening. And this is my contact information, so you're welcome to reach out to me if you have questions about anything. And then I am happy to take any questions that we might have.
Thank you so much for that presentation. There were moments where I felt like a bobblehead because I was just nodding along with what you were sharing. We have had lots of engagement in our chat. We have lots of our adult preemies joining us today. And so one of those is Juliet. And she had a question about how psychologists may support the whole family and siblings of the NICU infant. And so is that something you address in your NICU?
Yes, that's a great question, Juliet. So, we have a very robust program for our NICU siblings because we know, again, the whole family system is experiencing stress. And even when the sibling is young, so I'm working with a family now where kiddo whose birthday is in a couple of weeks, 1 year birthday, they have a 2-year-old. So for the last year, this toddler, the sibling, has had to deal with parents who are incredibly stressed. And of course, that impacts their parenting with her. And so we have a wonderful child life team, and their specialty is siblings. And so we have sibling books that we give about the experience of the NICU. I coach a lot of our parents on how do you talk with a 2-year-old about their sibling being in the NICU. How do you include them? How do you expose them? This particular baby is going home with a trach and on a vent. And so we have little dolls that have, pretend trachs where we can coach the baby or the toddler on baby has a trach. These are the things you don't touch. These are the things you can touch. And so siblings are very much a part. And in some cases, we have had older siblings. So say, for example, an 8 or 9-year-old, and we are able to engage in therapy directly with that sibling to help them process, whatever feelings they might have that mom and dad are gone a lot, or they see them crying a lot, or all their weekends are now spent with grandma and they don't get to see their parents. And so it can be really hard for the siblings as well. That's a really great topic that you brought up.
Gigi, who was our guest not that long ago, she wanted to ask, she loved that you mentioned about trauma being multifactorial, and by default, any intervention should also be comprehensive. So what do you recommend should be the first step towards addressing these complexities in the NICU? Is it increasing awareness first as first step towards facilitating a cultural shift in how babies and families are supported?
Yeah, I think that's where it starts, the education piece, because especially for our medical teams, because what I have found specifically at our NICU is that we're really good at the medical aspect of care. It's what people have been trained for, it's what they're passionate about. They're highly skilled to be able to work in a NICU and know how to intubate, a 1-pound baby. So that part they do really well. But many of them have not even considered some of the cultural aspects and how that plays into how families show up at the bedside, or the trauma-informed aspects that might impact why a parent responds the way that they do when the alarms go off, or that if they've had another baby that they lost, or like a parent that I worked with who the mom had 11 miscarriages before this baby in the NICU, and how this baby is their prized possession. So of course, they're going to be hyper vigilant. They're going to be involved. They're going to ask a lot of questions. They're going to question everything that's happening. And oftentimes for the medical team, that can feel like a difficult parent. That can feel like a parent who doesn't trust the medical system. And while it might be experienced that way, the parent has some very justified reasons for showing up the way that they are. And so at our unit, we have a trauma-informed care team in our NICU. And we've done a lot of work over the last 5 years of educating our whole unit about cultural sensitivities and trauma, so that our medical team can then have the understanding that we have, as psychosocial people, about the experience of parents and how that shows up at the bedside. And we did a training over 2 years And there were many, many hours. We had like a 16-hour series that every person had to go through over the course of a year. And it was
Wow.
our docs, our nurses, our unit secretaries went through it, our therapists, everyone that works in the NICU went through this trauma-informed care training series so that they could have the understanding and perspective. And now we're rolling out more of the application base of it, because sometimes you have the knowledge, but then you don't know, okay, how in the moment do I engage those skills? And so now we're working on that piece. But I think the first step is providing the education, because oftentimes that is not a part of the medical training.
We also have Sandy joining us, who is also an adult preemie, and she has now studied to be a NICU nurse. I fielded her question, but I told her, she asked if all Canadian NICUs have psychologists. So I was able to answer that for her and say that we don't. But I wondered if you could shed some light on the American situation. How about the US NICUs? Would it be more commonplace for there to be psychologists in the NICUs?
Well, that's a really good question. And I'm curious if any of the NICUs in Canada have a psychologist.
There are some, I know, but not all by any means. Yeah.
Yes, and not all by any means in the US either. Usually, NICUs that do have a psychologist are level 4, so that highest level of acuity. And then, like I said, over the last 10 years, it really has grown. So in our national network of NICU psychologists, which was created in 2016, I have seen the numbers of psychologists that are a part of that. And we're a small, as far as a field, we're a small field. So usually we know each other, but that group has grown from 20 to 50 to 80 psychologists over the years. And now I think we have over 100 members. And I'm always seeing new NICU psychologist positions posted. And also there's more training experiences. So for many of the people like me who started 10 plus years ago, we didn't get formal training on being a NICU psychologist because there were not opportunities. I did my fellowship in infant mental health, and I was always interested in trauma. And so the NICU was, just the perfect place to bring both of those together. But my job as a NICU psychologist was my first time physically working in a NICU. And so it's nice to see more training opportunities popping up, because then that will also help support the growth of the field. So I don't have an exact number for you as far as how many NICUs in the US have psychologists, but I can say it is a growing number. And, my professional goal is by the time I retire, every NICU would have a NICU psychologist, because I think, when you listen to the things that I've been talking about, it's like, what better place would there be for a NICU psychologist, or for a psychologist but the NICU?
Ashley, one of our viewers who was also born prematurely in the 80s, she shared a beautiful example in our comments just about the importance. She was followed by a psychologist, and so could attest to the importance and the value of that personally. I do have a practical question for you.
Yeah.
And that is, you had done this awesome Venn diagram with the social workers and the psychologists. And I'm wondering if when people refer a family, then does it go to, do you have kind of a whole psychosocial team that works together to decide who would be the best fit? Or do social workers meet everybody and psychologists only meet a few? Or how does that work in your NICU?
Yeah, that's a great question. So whenever someone places a psychology consult, it is between myself and Dr. Williams, who will see them. Our social work team pretty much meets every single family. So they're divided by teams. So whoever is admitted on their team, at some point they have an interaction with them, just because of some of the things that they help the families to manage and deal with. However, we do have something called psychosocial rounds, and those happen every other Tuesday. And psychosocial rounds includes all of our psychosocial support teams. So it's the social workers, psychologists, our child life specialists, our chaplains, our lactation consultants, our palliative care team, and our parent support specialists. And what we do when we do the psychosocial rounds is we run through every single family that's admitted in the NICU, and we talk about, what's going on with the family psychosocially, or if there's a big medical thing that's coming up or just happened, so that we make sure no family falls through the cracks. So oftentimes in that setting, we get referrals. So somebody might say, this family just failed extubation and they're having a really hard time. Mom and dad have been really crying at the bedside a lot, and we think they could use some additional support. Okay, there's a psychology consult that comes from that. Or we might say, siblings are having a really hard time. Then child life gets involved. Or, this family is, they believe strongly in their faith and they're really struggling. Okay, the chaplain then knows to deploy and, build a relationship with that family. And so we really use that time to make sure everybody who needs to be involved can be.
And did you say that's weekly, those rounds?
They're every other week.
Every other week. That's amazing to have the whole team together.
Yes.
Also wondering about if a family already has therapy outside of NICU. How do you work within that? Are you in touch with them? Does that contribute to the larger picture of the family's health, or how does that fit in?
Yeah, that's a great question. So typically, we want families to have kind of our psychology ethical approach is for families to have one psychologist or one therapist. It doesn't have to be a psychologist. However, when they're in the NICU, this is such a niche area. This is such a unique area, and a lot of therapists in the community don't have the frame of reference and understanding of the NICU environment and the diagnosis and all of the things that families go through, or even of that infant mental health component. And so sometimes what we do is we continue to see, or if there's a consult place, we will see the family in conjunction with their other therapists. So for example, I have a family right now, the mom has her own therapist that she had prior to being in the NICU, and they still get to work on the things that they've been working on. But the work that I get to do with her is around their NICU experience, is around her attachment and bond to her baby. It allows me to be able to liaise with the team about things that are going on and advocate for mom in a way that her community therapist wouldn't be able to. So there are occasions where families have an outside therapist and also see us as well. But that's rare.
Well, we do have to wrap up our time together. So I appreciate you sharing your wisdom today. And I have to tell you, I loved all the stuff you talked about with the whole family health, the attachment and the bonding and the value of that. And you made a comment in there that it was passing, but as a parent, I so appreciated it. And it was talking about even announcing, as staff, announcing ourselves to babies and prepping them for what is about to happen. And I just think that is, to me, on the cusp of something greater that we're heading in the direction of. And that is respecting babies as people and developing that relationship with them. So I appreciate you making that comment today.
Yeah, that's so important.
So thank you for joining us. And I'm glad that you also shared your contact details. Please reach out to Tiffany if you have any more questions or want to lean on her expertise that she shared today. There was so much good stuff packed in that presentation. So I hope people have a chance to rewatch it and digest some of it. So thank you, Tiffany, for joining us today.
Thank you, Leah. And thanks everybody for listening and for your engagement. I really appreciate it.
And thank you, everyone, as Tiffany said, for joining us and engaging. It is through these conversations where we share some of our stories, where we share our wisdom together, where we can, like we said, advance practice in NICU. If you missed any part of today's episode or you want to rewatch it, then again, go to CanadianPreemies.org. Check out our past episodes, or it's on our YouTube channel as well. And while you're there on CanadianPreemies.org, just explore. There are so many free resources and support options that we offer to help families on their journey. CPBF is a charitable organization, and we rely on generous people like you to keep our programs up and running. Your donations allow us to continue empowering families of premature babies every step of the way. And you probably have heard, I hope you have heard, if you follow us at all, that one of our biggest fundraising efforts is happening this fall, Little Lights, Big Hearts Gala. And I'm going to let you know that you only have another week to get early bird gala tickets. So this is your chance. If you've been waiting to get your tickets, please make sure you get them next week. This is something that we're using as our primary fundraising event this year. And it really does make a difference in helping CPBF continue to create brighter futures for all of our NICU babies and their families as they're out of NICU as well. It will involve great dining, awesome auction items, and just a time to connect with people who are also passionate about premature babies and their family. Thank you, everyone, for being a part of today's episode. Have a great weekend, and we will see you here next Friday for another edition of Preemie Chats.